Uh, a warm welcome to everyone to this LMHI Global Colloquium. It's 9 December, 7:30 a.m. IST, and a very good morning and good evening to people who are joining from across the globe from other time zones. I am Dr. Cheshta Nagrat, SMO, Directorate of Ayush, Delhi, India. I would be the moderator for this session, along with Dr. Thankaraj Balakrishnan, who is an associate professor at NHMC, India.
Thank you, Dr. Cheshta, and a warm good morning to all. The theme for today's session is case reports, observational, pragmatic, and randomized control trials. And the sub-theme is on randomized control trials. Over to Dr. Cheshta.
Yeah. Today, our session, we have two chairs with us, and Dr. Suniti Chuk, she has joined, and she is a research officer homeopathy with Ministry of Ayush, India. Welcome, Dr. Suniti Chuk. And along with this, today we have esteemed presence of Director Ayush, Delhi, Dr. R.K. Manchanda. And I would like to invite Dr. Manchanda for some opening remarks. Over to you, sir.
So thank you, Cheshta. First of all, I would like to say good morning, good evening, and good night to many of our colleagues joining across the globe. And as you all know that this is a very unique attempt LMHI has taken up to unite homeopathic forces across the globe. So I hope it is a very compact program. There is no time to give long lectures either in the beginning or towards the end. But I would like to say that please enjoy each moment of this colloquium. Thank you very much for joining this so early and delivering this lecture. But it's a unique opportunity for all of us to work for 50 hours. That is going to start on 10th December, 1300 CET. Thank you.
Thank you, sir, for the encouraging words. We have now, I would like to invite Dr. Souvik Datta for the first presentation. Dr. Souvik Datta is from D&A Homeopathic Medical College and Hospital, Kolkata, West Bengal, India. The title of his abstract is The Efficacy of Individualized Homeopathic Medicines in Intervening the Progression of Pre-Hypertension to Hypertension, a double-blind randomized placebo-controlled trial. Over to you, Dr. Datta.
Am I audible?
Yeah, you're audible. You can share your screen.
Okay. Hello. Good morning to my respected. Good morning to my respected dignitaries, and thank you LMHI team for giving me this opportunity. I am Dr. Souvik Datta, MD, Organ of Medicine, Department of Organ of Medicine, D&D Homeopathic Medical College and Hospital, West Bengal, Kolkata. Today, I am going to present my poster on efficacy of individualized homeopathic medicine intervening the progression of pre-hypertension to hypertension, a double-blind randomized placebo-controlled trial. So, all you can know that pre-hypertension is basically the hypertension range from 120 to 139 SBP mmHg, and DBP is 80 to 89 mmHg. Though it's a preclinical condition, but it may lead to CVD or hypertension in near future. A recent study from urban population in North India also found a prevalence of pre-hypertension 31%. So in this study, we attempt to study the efficacy of effects of individualized homeopathic medicine in comparison with placebo in intervening the progression of pre-hypertension to hypertension. Now, the main aim of this study is to evaluate the efficacy of individualized homeopathic medicine against a placebo in treatment of pre-hypertension, and to compare between the introduced homeopathic medicine and the placebo in measures yourself medical outcome profile. It is a MIMOP score. Now the study design is basically it is a double-blind study and randomized and placebo control and 2 parallel trial. The study setting in the outpatient department of DN, the Homeopathic Medical College and Hospital. We have 92 sample size and 46 in each group, both Veram and placebo group. Total study duration was 17 months and the study was ethically certified and CTA registered. Basically, the inclusion criteria are the adults for both sexes, age 18 to 65 years, subject with a pre-hypertension as per the criteria, and the newly diagnosed patient with pre-hypertension while completing the other functional disorder or the family history of hypertension. And the patient must have to literate with known ability to write or read English and Bengali with provided informed consent form. And the exclusion criteria are pregnant or lactating women, pre-existing chronic debilitated illness, subject on hormonal contraceptives, steroid or non-steroid anti-inflammatory drugs, any uncontrolled systemic or psychiatric illness, life-threatening illness, self-reported immunocompromised patient, and the patients who are undergoing the treatment for any chronic conditions in homeopathy within last 6 months. In case of the intervention arms, we have 2 arms, the Veram and a control. The Veram group contain the introduced homeopathic medicine in centesimal potencies for 3 months and control identical looking placebos for 3 months. And in both arms, we gave DASH style diet and bricks physical activities for 3 months. We have 2 outcome measures. One is the primary outcome, this is systolic and diastolic blood pressure, and the secondary is MIMOP2 profile scoring with having the 4 components. The timeline is basically baseline and every month up to 3 months. And we used the intentional treat analysis statistical method with intra-group difference on one-way repeated measures ANOVA and intergroup differences using the unpaired t-test and two-way repeated measures ANOVA. We basically screened total 118 patient and excluded 26 patient as per exclusion criteria, and we categorized total 92 patients and give them in the 2 one in homeopathic and LSM, that is the 46 patient, and other in the placebo 46 patient. And in case of result, the baseline 2 groups were comparable at baseline on confounding factors, and the primary outcome is the reduction in blood pressure was basically non-significantly higher in the IHM group than placebo with a small effect size. Except diastolic blood pressure in the placebo group, all intergroup changes over time in 2 groups were statistically significant. Secondary outcome, intergroup changes over first, second, and third months revealed significant improvement in both Veram and the placebo groups. Group differences favored IHM against placebo, but it's statistically non-significant. So you can see there is a DBP only in the month 1, and this p-value is 0.0303. That is a less than 0.05. And here's the box plot diagram of this is the introduced homeopathic medicine in SBP condition, and this one is the placebo. Here also the DBP in case of IH group and is the placebo, and is the MIMOP profile score in case of IH group and is the placebo. So we use basically introduced homeopathic medicine in that particular condition, and we used strictly on the principles of homeopathy, and we used total 19 medicines. There is the frequently prescribed medicines were lycopodium clavatum, metramute, thuja, and sulfur. Total 18 minor adverse event and 20 minor adverse event occurs in Veram group and a placebo group respectively. So in discussion part, I would like to say basic strength of this study is randomization, double blinding, intention treat analysis, and we strictly follow the classical principles of homeopathy with consult and red hot guidelines for trial reporting. The main limitation of the study is basic that time, and its time is inadequate. A longer follow-up might have been more beneficial for that. And obviously the COVID-19 pandemic situations that hampered the and that also result the dropout, 16 dropout. The main future research aspects maybe the independent replications are warranted to arrive any conclusive recommendation of use of IHM in treatment of progression of pre-hypertension to hypertension. So I like to conclude in that case, say that this particular trial, basically non-significant direction of effect favoring the homeopathy against placebo could be observed, which ultimately rendered the trial as inconclusive. And mutual administration of LSM in both groups might have reduced the effect size, and the detection of the group difference is difficult. And this particular paper was published in the Explore journal, and it's also PubMed indexed. So thank you LMHI for giving me this opportunity.
Thank you, Dr. Souvik, for the lucid presentation. Now I would like our chair, Dr. Suniti, to share her views, or if she has some questions, she can put those across.
Yeah, Dr. Souvik Datta, I would like to ask you whether you included all the patients with any other comorbidities such as diabetes or some other comorbidity in the test your study.
Yes, ma'am. If the patients having a diabetes or control condition, having the modern medicine for the diabetic condition, then I can include that patient. I also included a particular patient.
But don't you think that the patients who are under some other treatment or other modern medicine system treatment, they would hamper the results of the study?
Ma'am, patients having had the anti-hyperglycemic medicine, and as per my research, anti-hyperglycemic medicines little or minimal effect on the hypertensive condition or pre-hypertensive condition.
Because generally we see that hypertension and diabetes in many patients, like these two conditions coexist, and individually when the patient is only hypertensive, there might be some difference in the results that we observed in the study. And one more thing I would like to ask you, in your exclusion criteria, did you exclude the patients who are on some other modern medicine treatment for hypertension?
Yes,
or the pre-hypertensive condition? Because yes, I think it was not mentioned in your exclusion criteria.
Yes, I exclude those patients who have been, yes, I excluded.
Okay. So when did this study was conducted?
The study was conducted in between 2018 to 2020, 17 months duration.
Okay, you said that there was some effect of follow-up due to COVID-19. So yes, it was going on during that duration when there was a...
Yes, because this one is my postgraduate thesis, so this quite hampered my dissertation also, this pandemic situation.
Okay. So it was a nice effort, nice study you have taken, and it is you should go with the larger sample size to reach to conclude.
Yes, obviously.
Yeah. Thank you.
Thank you, ma'am.
Yeah. I think we can go ahead with the next study. Yeah.
Sure, ma'am. And ma'am, just to add, you need to evaluate the posters as well on a scale of 1 to 10.
Right. Yeah.
Yeah. Thank you, ma'am. Thank you so much. Next, we have Dr. Nilanjana Guha with us. Dr. Nilanjana is from Mahesh Bhattacharya Homeopathic Medical College and Hospital, West Bengal, India. And the title for her poster is a double-blind randomized placebo-controlled clinical trial to evaluate the efficacy of homeopathic medicine in pre-diabetes. So welcome, Dr. Nilanjana, over to you. You can share your screen. Dr. Nilanjana, you can go ahead.
Yes, respected chairpersons, moderators, and delegates, very good morning to all. Is my share visible?
Yes, it's visible. Please go ahead.
Okay. So the study I have conducted during my post-graduation, that is double-blind randomized placebo-controlled clinical trial to evaluate the efficacy of homeopathic medicine in prediabetes. This is my topic. So As we know that diabetes mellitus has become the commonest chronic disease worldwide, and uh, the prevalence of diabetes mellitus in worldwide is 425 million in currently, and it will become 629 million by 2045. So for India, it is the count is now 31.7 million, and it will become 55 by 2030. And if we add the prevalence of impaired fasting glucose and impaired glucose tolerance, the number will be 79 million. So talking about the impaired fasting glucose and glucose intolerance is that these conditions are pre-diabetic conditions, which is intermediate hyperglycemia, where IFG counts for 100 to 125 mg per TL blood glucose, and IGT is 2-hour post-load glucose for 140 to 199. That is the below the range of diabetes. But this pre-diabetic state leads to the diabetes in 6 years to 10 years. So why I took up this pilot study with no previous existing publishing in homeopathy, that we see that diabetes mellitus has become a huge economic burden for both individual and nation. Moreover, in our country, where more than 70% diabetic patients are treated by private health sector, it exerts a huge economic burden. So we could control, if we could control the diabetes from its beginning, it will be good for us. And the existing the existing studies shows that lifestyle modification is the first line intervention to stop or delay pre-diabetic patients to become diabetic. But implementing lifestyle modification itself has been a challenge across the globe, as it has poor long-term compliances and involves excessive human resources. Uh, so, at this point, conducting a study on efficacy of homeopathic treatment to prevent diabetes will be one step forward in making the treatment cost effective. So my aim of the study is to evaluate the efficacy of homeopathic medicine in comparison with placebo in preventing progression of prediabetes into diabetes.
Excuse me,
So,
Dr. Nilanjana, can you just zoom in your screen? Your poster is not, text is not visible.
okay.
And you scroll it little up, little zoom.
Yes.
Yeah, now it's okay. You just, yeah, that is better now.
Okay.
Thank you.
Okay. Thank you. So coming to the material and methods, the trial design was it was a double-blind randomized placebo-controlled two parallel clinical trial, which is registered under CTRI, and the study was taken in OPD and IPD patients of our college, which the total period of time was 18 months, and each patient was given 6 months for follow-up, and the sample size was taken as 30 into 2 with the power of 80%, with attrition for attrition rate up to, we took expected attrition rate up to 20%. The exclusion and inclusion criteria was strictly maintained all through the study, and with all this included in this poster. And the intervention was, the Veram was individualized homeopathic medicine in centesimal potency only, and the control group was as identical looking placebo. And with this, we had given the concomitant care of lifestyle modification. So coming to the results of the study, that there was group differences were comparable at the baseline was found. There is no the differences was not statistically significant, as a p-value is more than 0.0. 5, and after the study, the attrition rate was 10. That is, there was for the 6 patients, 4 from code 2 and 2 from code 1. And the intergroup differences after 6 months, it can be seen in this chart also, that I individualized homeopathic medicine and PL medicine in FPS, it was statistically significant after 6 months. This P was less than 0.001, but in post-load glucose, it was not statistically significant after measuring with ANOVA. And we had taken another scale to determine the group differences, that is diabetic symptom, that is SDSCR, for it was also statistically significant, this score. So after considering the patients who were advised with lifestyle modification along with the treatment, the null hypothesis versus no effect we discarded, and alternating hypothesis of the probable treatment was accepted. During this study, no harm or serious adverse event were recorded, but as there was pandemic, there was intermittent illnesses, but we treated with medicines other than coded medicine. But it was mainly acute complaints, and we don't think it would hamper the treatment we given. And for the suggestions, the primary question is if only homeopathic treatment is sufficient to reduce blood glucose level, which was my study aim. So uh, but we implemented lifestyle modification. So there are already many established studies that have shown dietary restriction and physical activity have effectively prevented the conversion from pre-diabetic to diabetes, that lifestyle modification. But there should be studies showing that if only homeopathic medicine is effective efficacy with the comparator arm of LSM, so we can know that if my study is compounded by the compounding factor was LSM, we cannot surely conclude that it was a lifestyle modification or homeopathic medicine which but lifestyle modification was in both arms. But as I conducted the study, the patients who actually did the lifestyle modification, those were
Dr. Nilanjana,
okay.
you are requested to kindly wrap the poster presentation and conclude it, as we are running short of time.
Okay. And also there is we use only centesimal potencies. The efficacy of mother tincture or 50 millisimal potency was not was untested. There is we should do a multicentric study, and with more longer duration and larger sample size, which will make the result more acceptable. Okay, this I now I conclude my session.
Okay. Thank you, Dr. Nilanjana, for a descriptive presentation. Now I would like Dr. Suniti, if she has to ask some questions or give some remarks.
Yeah, Dr. Nilanjana, for how much duration was the study period was for how much duration?
It was 18 months during my post-graduation tenure.
That means 2.5 years. So impaired glucose test and impaired IGT and IFT were the only criteria you took for the assessment?
And the DSCR score. I took HbA1c also, but for due to we cannot do this in my hospital. Many patients refuse to do this, so I have to take this
Because
criteria out.
because HbA1c is considered to be a
Yes, ma'am.
very important criteria for assessment of the
Yes, ma'am.
progress.
We took initially we took HB1C, but during result we had to uh,
And
remove
as you
the criteria.
said that lifestyle management is important part, and a study has to be conducted to show whether it was a lifestyle management which has really affected
Yes.
or the homeopathic medicines.
Yes.
So you took all the patients to this protocol of lifestyle management, and they were following the this protocol.
But I what I remember that in my in my placebo arm, I think the code I was not it was not in disclosed, but in code 1 more than 15 to 17 patients were taking lifestyle modification. They also lost weight during the study, 1 or 2 kilos, but they were taking lifestyle modifications. But in code 1, there was less patients, like this 10 to 11 patients were taking lifestyle modifications. And there was also another factor, that age and more more that is the patients with lesser uh, the blood glucose level, they are come to below the blood pre-diabetic level, but who have the more blood glucose level, they do not come under the non-diabetic limit.
So it is suggested that these standards have to be, taken into consideration when
Yes.
taking, and the larger
And
sample size and for a longer duration studies are required.
yes,
And
on our precise some precise scoring system, because what scoring system I took, it was for diabetic patients, the over diabetic patient, not pre-diabetic.
not for
DSCI score.
pre-diabetes. Yeah.
Yes,
And there
because
should be involvement of the dietetics in this also study also, so that there is aggressive follow-up of the lifestyle management and the diet, which is one of the important
yes,
criteria for this. Yeah.
yes.
Okay. Thank you.
Okay, thank you.
Yeah, we go ahead with the next study, please.
Okay, ma'am. The next speaker, I would like to invite Dr. Satyarupa Sadhukan. She is a senior research fellow with Central Council for Research in Homeopathy, India. And her abstract ID is 55, and the title is Individualized Homeopathic Medicines in Stage 1 Essential Hypertension, Double-Blind Randomized Placebo-Controlled Pilot Trial. Over to you, Dr. Satyarupa.
Thank you. It's a great pleasure to attend such an international platform. I'm going to share my screen. Okay, is it visible? I think my screen
Yes, your screen is visible. Okay. Yeah, you can go ahead.
Okay, thank you. So my study is individualized homeopathic medicine in stage 1 essential hypertension. It was a double-blind, randomized, placebo-controlled pilot trial. So it was a pilot trial because we had to keep our sample size smaller because of it was also a PG dissertation. So by keeping the time limit in mind, so we had to keep it in as pilot trial. Background of the study is hypertension is a frequently encountered condition in homeopathic practice, whether we measure it or not. But whenever we measure, we find frequently this patient are having hypertension silently, or sometimes patient also themselves say that they are having hypertension. So however, no randomized control trial on hypertension has qualified for the meta-analysis of double-blind RCTs on individualized homeopathy that was done in the year 2014. And the current trial was undertaken as an external pilot to explore the feasibility of a definitive and adequately powered trial on individualized homeopathic medicines versus placebo in stage 1 essential hypertension. And we, along with that, we also added the lifestyle modifications that were diets and exercises. Our main objective was to assess the feasibility of a definitive placebo-controlled trial for evaluating individualized homeopathy in stage 1 hypertension. So our study design was exploratory, double-blind, randomized, placebo-controlled, 2 parallel arms. We conducted this study in the OPD of National Institute of Homeopathy, and our sample size was 68. The study that I had taken into consideration that was done by Dr. Sahab. According to that, if we had to calculate our sample size, it would have become 394 patients in one arm. So we, keeping in mind the time limit, so we just target to achieve 8% to 10% of that. And finally, we reached 68 samples. Now, so our study period was from March to December 2018, only for recruitment, and another 6 months for the final follow-up. So this trial was registered under CTRI. We included only those patients who are suffering from stage 1 hypertension only. That is systolic was 140 to 159, and or anything diastolic 90 to 99, either both or any one. Okay, and the age group was 18 to 65 years of both the sexes. And as we used MIMOP questionnaire, so we had to keep literate patients only, and those patients who gave their written informed consent. And we excluded those patients who were too sick for consultation and who were diagnosed with unstable mental or psychiatric illness or other uncontrolled or life-threatening illness affecting quality of life or any organ failure, pregnant and lactating mothers, substance abusers or dependent, and also those who are having immunocompromised state. Those patients already undergoing any other chronic treatment, so we excluded those also. Now our outcome assessment was the blood pressure measured at baseline and after 1 month for the next 6 months. And another thing was MIMOP version 2 that was assessed at baseline at the end of month 2, month 4, and month 6. So we use ITT approach so to replace the missing values and analyze by that way. So most indicated medicine we found were pulsatilla, natramur, thuja, sulfur. These were so this is a study flow diagram. I'll zoom it more further. We included 153 patients were screened, but we had to exclude more than 50%, that is 55.56%. So most of them was illiterate, as I already told earlier, that we could not assess the MIMOP scale, and very severe condition was there in 3 patients. We had to exclude them. Consent was not given by 9. There was uncontrolled diabetes, uncontrolled hypertension. Few patients were already undergoing homeopathic treatment. Few patients were already undergoing allopathic treatment. So we had to exclude. So in this way, we find that recruitment rate is very low, below our. So we enrolled 68 patients and randomized them into 2 arms, in individualized homeopathic arm and in placebo arm. So in homeopathic arm, 6 patients lost to follow-up. We followed up finally up to 6 months, 28 patients. And in placebo, we followed up 30 patients. So using ITT, we finally analyzed all the 68 patients. Now the major strength of the study was randomization. It was double-blinded. We used ITT analysis, and it was strictly adhered to classical homeopathic principles. All the patients were given individualized homeopathic medicines only, and DASH and other LSM guidelines were also given to each participants to counter the ethical issues. The small sample size that I have already told, it was the major weakness. So we had to compromise the power of the study. The post hoc calculation, it came, we find it to 15%. So the results may not be interpreted in general. So after, and the major challenge was illiteracy, low recruitment rate, and as it was pilot trial, we only had 85 medicines. So the limited number of available medicines is another challenge. Okay, and now the field for future research are like adequately powered definitive trial may be adopted. So finally, whatever recruitment rate was low, but retention rate was promising, it was more than 80%. So adequately powered definitive trial may be adopted, And next thing is run-in period may be maintained to exclude patients showing spontaneous improvement. So the minimal clinical important difference MCID was found to be 20 millimeter of Hg. Could not achieve in our study. So a systematic recruitment strategy, adequate reference and publishing may be considered for this. Though the recruitment difficulties were identified, adequately powered trials appears possible in the future. And this study is already published in ACM in this year only. Okay, this is from my side.
Yeah, thank you, Dr. Satarupa, for the comprehensible presentation. Now I would like Dr. Suniti, if she has some questions.
Yeah, Dr. Satarupa, it is a nice study you have undertaken, but as you yourself have mentioned, the sample size was quite low. And yeah, although retention size was good, but you have to take up this study in a much larger, on a much larger scale. And maybe a lot of studies are there on the essential hypertension. So all the flaws and the such these which may be examined in the previous undertaken studies, and that you can take up in your future studies with the larger sample size.
Yes, ma'am. Thank you.
Yeah, I think we may go ahead with the next one.
Yes. Next, we have Dr. Laijun Nahar, who's from the Regional Research Institute for Homeopathy, Agartala, Tripura, India. And she's a research officer there. The abstract ID is 83, and the title is An Open Label Randomized Pragmatic Non-Inferiority Pilot Trial to Compare the Effectiveness of Dysentery Compound with Individualized Homeopathic Medicines in Irritable Bowel Syndrome. Over to you, Dr. Laijun.
Good morning to all of you.
Please share your screen.
Yes, ma'am. I shall I say. No, I have some problem to share my screen.
Any message that's cropping up there?
No, ma'am.
Are you still facing some problem?
Yes.
Can we
move to next?
Yeah,
We can
it's
take
visible.
a study later.
Yeah. Okay.
Just
But her screen is visible now.
yeah, now it's visible.
Yes.
Your screen is visible, Dr. Laijun.
Okay. Thank you. Yes. Title of my study is An Open Label Randomized Pragmatic Non-Inferiority Pilot Trial to Compare.
Dr. Laijun, your screen is not visible. The presentation slide is not visible.
Now, ma'am, visible?
No. The slide, it's not open.
Dr. Nahar, please stop sharing and then open the slide and then share again, please. Open the slide first and then share again.
Ma'am, visible?
Yes, it's visible now. You can zoom in a bit, and then you can move forward. Yeah. Yes, you can start.
Title of my study is an open label, randomized, pragmatic, non-inferiority pilot trial to compare the effectiveness of dysentery compound with individualized homeopathic medicine in irritable bowel syndrome. Irritable bowel syndrome is one of the most frequently encountered gastrointestinal disorder globally, distressing 10 to 20% of the adult population. Severe IBS can significantly alter quality of life, disrupt daily activities, and result in inflammation.
Dr. Lyjan, you are not audible.
Hello, ma'am.
Now you're audible. Go ahead.
Oh,
পটে করতে গিয়ে লেট হয়ে গেছে
aims of my study was to compare changes in irritable bowel syndrome quality of life questionnaire score between dysentery compound and individualized homeopathic medicine after 3 months of interventions, and to shortlist the most frequently indicated individualized homeopathic medicine. It is an open label randomized pragmatic
Dr. Lyjan, you're again not audible.
Hello, ma'am.
Now you're audible.
Okay. Inclusion criteria of the study was patients suffering from irritable bowel syndrome as per ROM3 diagnostic criteria and symptomatic for at least 2 days per week over 3 months of 3 months. Both sex age 18 to 65 years, literal patient with ability to read Bengali and or English, and patient giving written informed consent. Exclusion criteria were patients who were too unwell to take part, diagnosed cases of
Doctor, you're again on mute. Yeah. Please carry on.
Okay, ma'am. Outcome measures were used: irritable bowel syndrome quality of life questionnaire, Bengali version. Sample size were 60. Both arm 30% were included. Timeline, baseline, and after 3 months of treatment are included. Statistical analysis were both intention to treat and per protocol analysis. Both are used. Group difference are using unpaired t-test and non-inferiority analysis. Result were homeopathic medicine over dysentery compound, but group difference was statistically non-significant. Non-inferiority test was demonstrated by dysentery compound against individualized homeopathy over 3 months of treatment. In this study, most frequently used homeopathic medicine were Nux vomica, Argentum nitricum, Mercurius solubilis, Natrum mute, Natrum salve, Pulsatilla, Thuja occidentalis, etc. Strength of this study was randomization. Intention to treat
You are not audible, Dr. Lajan. Dr. Lajan, you are not audible.
Hello, ma'am. Am I audible?
Yes, now you are audible.
Yeah.
Oh. Limitation of this study was underpowered, of small duration, use of a single outcome measure in terms of IBS quality of life questionnaire, absence of any homeopathy specific outcome measures, that is Glasgow Homeopathic Hospital Outcome Scale. Future research. further exploration of both efficacy and effectiveness either of the therapies is necessary.
Dr. Lyjan, you are again not audible. Still not audible.
Ma'am, am I audible?
Yes, now it's clear. Please continue.
Conclusion of the study was non-inferiority of dysentery compound against individualized homeopathy treatment of irritable bowel syndrome was not demonstrated, though it appears as safe. Still being a pilot trial, no definite conclusion could be drawn. This study was published as Journal of Complementary and Integrative Medicine by D. Gruyter, and this was in
I think Dr. Lyjan is, yeah. So you have concluded your presentation, Dr. Lyjan?
Yes, ma'am.
Okay, I think it's because of some signal issues, you were getting inaudible in between, but now it's clear.
Yes, ma'am.
No. It's perfectly fine. It's an online platform. Thank you so much for your efforts and a good presentation. Now I would like to request Dr. Suniti Chugh for her expert comments and any questions.
Dr. Lajan, basically it was a sample size, larger sample size, and placebo controls are required for taking up studies. And so as you know, the RCTs are the gold standard. So this can be taken up later at a larger scale and with the control trials. Yeah. Thank you.
Okay, with the permission of,
yeah. Sir, over to you.
Yeah, thank you, Doctor. With the permission of the chair, let me invite our next panelist, Dr. Ruchita Sharma. Dr. Ruchita Sharma is an assistant professor at SK Homeopathy Medical College and Research Center at Jaipur. The topic is effectiveness of homeopathy medicines in case of polycystic ovarian syndrome and its influence on the quality of life, an open, randomized, placebo-controlled trial. Her abstract ID is 135. Over to you, Dr. Ruchita.
Have a lovely morning to everyone sitting here. So not taking too much time. So I want to start with my PhD thesis. It was on effectiveness of homeopathic medicine in cases of polycystic. I think my slide is visible to all.
Yes, it's visible.
Okay. Yeah. So it is on effectiveness of homeopathic medicines in cases of PCOS and its influence on quality of life. As from the previous researches, I came to know that we very well know that PCOS affecting, it is a multifactorial endocrinal disorders. But nowadays, it is much more affecting the quality of life rather than only it is affecting the physiological or pathological conditions of a patient. So I started my study to, I decided to take the study on the quality of life apart from the controlling all the endocrinal parameters also. So I took the quality of life scale, that is MPCOS questionnaire scale. That was the latest one. Previously, the studies which was done, it was with a quality of life scale, that is PCOS. But I took on modified polycystic ovarian questionnaire. So my aim of the study is assessment of the role of homeopathic therapy in the treatment and improvement in quality of life of females suffering from polycystic ovarian syndrome. So the way I reached my aim is through sonography. I take all the parameters to control the ovarian size through the sonography. And I also judge my PCOS conditions with relating with the BMI, because in the previous researches, it was also there was a studies that somewhere and in another can be a reason. Obesity is the reason of PCOS, and as I'm the practitioner also, so I came into the practical problem that every patient is asking ki obesity की वजह से PCOS है क्या? If I am suffering from PCOS because of obesity, or PCOS is not reducing because of obesity. So I took this this as my one of the second objective. And lastly, I as I told you that I assess the PCOS quality of life from the MPCOS questionnaire. So the methodology which I used, I screened 125 cases, and after the screening, 55 cases are ruled out because of exclusion criteria. Because my inclusion criteria is the Rotterdam criteria, I took the Rotterdam criteria of inclusion. So which the patient who didn't fall in the Rotterdam criteria, I excluded the dropout cases and the patient who didn't give the consent. So and after all, overall, I took the study on the 70 cases, and after randomization, the 34 fall into the homeopathic group, and the second parallel arm was the placebo group with having the 36 cases. So the lifestyle management I give to the both arms, as this is a major region which can affect major reason which can affect the PCOS patient nowadays. As this PCOS is a syndrome, so we have to take all the parameters at a time. So that's why I decided to take lifestyle management in both arms. Apart from it, I also counsel my patient, whoever needed, because stress is also the reason for hormonal imbalance. So from the result which I get from my study, it was very good that in the homeopathic and placebo group, after the sonography results, after the sonography, I got the good results in both right and left ovarian size decreased in both the placebo group also, and in the right ovary also. But if we compare both placebo and homeopathic group, then in right ovary, there was a significant differences there. Means homeopathic medicine, the patient who is taking the constitutional homeopathic medicines, they have a good results with the because of the medicine rather than in comparison to the placebo group. But no doubt in the left ovary, I didn't get much significant reason. Might be that as we are giving both the lifestyle management, so they might be the good results in the one left ovary. Next, what I get the good result is on BMI. As this is obesity is a risk factor, or PCOS can be obese the patient, or if the patient is suffering from obesity, so he can suffer from the PCOD in later stages. So in the BMI, the patient having more than 25 BMI, according to the WHO scale, which I took, the patient are fall into my screening cases of inclusion criteria. And after that, I found that there is a significant difference between the patient who are taking the homeopathic medicines and the patient who are taking the second treatment, that is the placebo. Might be the reason BMI decreased in the both arms, but the more I got significant differences there, the reason is hirsutism and other hormonal treatment like thyroid, diabetes, and other reasons which cannot be treated without the medicines. That may be the reason the patient who are getting the individualized homeopathic medicines get good results in even in decreasing the BMI. Lastly, my third objective was as the quality of life parameters. It has the 6 domains. Previously, the PCOS questionnaire was using that was having the 5 domains as has 26 questions, and MPCOS modified PCOS questionnaires having the 6 domains and 30 question fall in it. The acne is included in this advanced PCOS questionnaire which I took. as the previous studies, I found that we cannot ignore the acne, because it has a near about 13 to 50% patients suffering from PCOS having a complaint of acne. And as I'm taking the lifestyle disorder patient affecting the PCOS, so this cannot be ignored for the females who are from the teenagers group. And my maximum age group is near about 20-25. So I found maximum PCOS cases in this age group. So I cannot rule out the acne. So I took this questionnaire. Apart from it, the other domains are infertility, emotional disturbance, menstrual irregularities, hirsutism. See, these are all the 6 parameters which I took. Definitely weight is also there. So I found in every domain, there is a decrease and there is a relief of the, and in many cases, they are cured also in both arms. But in modified...
Sorry to interrupt, Dr. Ruchika. You're all shoot your time. You're requested to wind up the session in another 1 minute.
Yeah. So I'm lastly taking the 2 minutes. So in the last, but hirsutism, I didn't found much relief in the placebo cases, because hirsutism cannot be treated with the medicines, without the medicine. That's why in MPCOS questionnaire, there was a significant difference between the placebo and treatment arm. The resolved cases is 4, totally resolved cases in the treatment arm, while it is none in the placebo arm. Improved was 28 in the treatment arm, while it is 23. The stationary condition was there in 1, while it is 8 in placebo. And there was a decrease condition of a patient in only in a 1 case in the treatment arm, while in there is a 5. Now I concluded my study within while taking the session, but the limitation I want to conclude that as the time period for study is less, so I need the number of cases increased, and other limitations are that it is very costly affair to take all the investigation at a time for a patient. So no single test is there for judging the PCOS. Only the single case is not single test we do not have yet, so that we can judge all the yes, this patient is of PCOS. So this is one of the limitation, and definitely one limitation is that we cannot control all the parameters at the time, and this is a syndrome. We cannot control all the parameters at a time. So this is another limitation. And my maximum patient are from the urban background. So might be the reason is from the rural background, patients are not aware what is the PCOS. So they do not approach to the doctors. So these are the reasons which are the limitations of my study, which can be overcome after the further studies. So I want to welcome the questions. Thank you from my side.
Thank you, Dr. Ruchika Sharma, for such for sharing the details of that exhaustive study. Now, invite Dr. Stuti Shukla for her expert comments. Over to you, ma'am.
Dr. Ruchika, what was the follow-up period of your study?
Ma'am, it was total 18 months. 1 year is for enrollment, and total 6 further months for the follow-ups. Total minimum 6 follow-ups I took for each cases. And next is up to the patient whenever the patient is coming, or if she is not cured till yet.
In such cases, we require long follow-ups.
Yeah, ma'am. Definitely.
Another thing is USG is not the only diagnostic tool which should be used, because as you know, there is insulin resistance in the PCOS. High insulin levels, and all this leads to it's not the obesity which causes PCOS. It is vice versa. It is PCOS which is causing increased insulin resistance and increased glucose, and that's why causing obesity and in high BMI. So other tests like insulin level of insulins in the blood and blood glucose levels, these are also important to be included in the study for the follow-ups, like how patients are doing, how these tests are going. Yeah.
Ma'am, while screening my patient, I did all this glucose tolerance test, thyroid, all the thyroid profile. During screening, I did all these tests.
But
And
the
yes,
follow-up also
I
is
agree that
required.
sonography is not the criteria. That's why I took the Rotterdam criteria for inclusions.
So basically, these also should be including for the follow. Maybe not very frequently, but these should be included in the
Yes,
follow.
ma'am, definitely. I took pre and post of thyroid and diabetes, both.
Yeah. Even insulin levels are also very important.
Yeah, ma'am. Pre and post. Yeah, pre and post. It is written in my all the dissertation work. I had written everything.
Yeah.
Yeah.
Okay. Thank you.
Okay, ma'am.
Yeah, I think we can go ahead with the
Thank
next.
you for LHMI for giving me this platform. Thank you, everyone, dignitaries sitting here. Thank you.
Next, I would like to invite Dr. Amit. Dr. Amit is the head of the Department of Repertory from RBTS Government Homeopathic Medical College and Hospital, Muzaffarpur. His topic is individualized homeopathy as an adjuvant in the treatment of gout, a placebo randomized controlled trial. And his abstract ID is 166. Over to you, Dr. Amit.
So thank you, sir. I hope my screen is on.
Yes, sir. Yes,
thank
sir.
you so much. And thank you, dignitaries, chairperson here, for giving me this opportunity. Thank you, LMHI. My topic today is individualized homeopathy as an adjunct in the treatment of gout, a randomized placebo-controlled trial. So gout is a painful, potentially disabling form of arthritis that has been around since ancient time. Earlier, it has been referred to as the disease of the kings because people long have incorrectly linked it to kind of overindulgence in food, wine, which only the rich and powerful could afford. In fact, gout can affect anyone and its risk factors, they vary. The first symptoms are usually intense episodes of painful swelling in single joints, most often in the feet and especially in the big toe. The swollen site may be red and warm. 50% of the first episodes occur in the big toe, but any joints can be involved. Fortunately, it is possible to treat gout and reduce its very painful attacks by avoiding food and medication triggers and by taking medicines. However, diagnosing gout can be hard and treatment plans must often be tailored for each person. In this homeopathic approach to the illness, the concept is to treat the patient as a whole and not only on the basis of the presenting symptoms. So in this, rather than treating the disease therapeutically, knowing a person's constitutional type helps the person choose the most appropriate remedy. So in this study, we have tried to compare the constitutional medicines with the medicines prescribed on the pathological basis. The aims and objectives of this study is to study the efficacy of homeopathic medicines selected on the basis of totality of symptoms in cases of gout, and second, to carry out a comparative analysis of the treatment of cases of gout with individualized homeopathic medicines and medicines chosen on the therapeutic basis. So the method that was chosen was a randomized trial of effects of the individualized homeopathic medicines. They were compared with the medicines prescribed on pathological basis in 60 patients with mild to moderate pain as a result of gout as an adjunct to conventional treatment. Now, the hypothesis of the study, improvement in cases of gout with homeopathic medicines prescribed on pathological basis, on pathological consideration, is statistically significant. And the alternative hypothesis stated that the improvement in cases of gout with homeopathic medicine prescribed on basis of individualized consideration is statistically significant. The inclusion criteria that was followed here was the patients of 30 to 55 years of age group suffering from joints pain, having serum uric acid level between 7 to 9 mg per dl. They were selected for the study. The data was collected, randomized. Case-taking proforma from our institute was used to collect the data, which included the name, age, sex, profession, socioeconomic status, duration of the disease, diagnostic and subsequent investigation, reportorial graph, and duration of the treatment. Assessment of the response and duration of the treatment was by serum uric acid level, observations along with general symptoms, weight, hemoglobin, and ESR level. The results The results, 60 cases were included in the study. Those who were meeting the inclusion criteria. The patients belong to various age groups with 34 males and 26 females. Out of the 60 cases, 30 cases were in the experimental group and 30 patients in the control group. 12 patients showed improvement in the experimental group and 20 patients showed improvement in the control group. Statistical analysis justified the alternative hypothesis as improvement in cases of gout with homeopathic medicines prescribed on the basis of individualized consideration is statistically significant. Treatment outcome was assessed on the basis of pathological reports and symptomatic improvement of pain in joints and general well-being. 4 categories of improvements were determined: marked, moderate, mild, and none. Complete reduction of joint pain with no functional disturbance and lower uric acid level was considered as marked improvement. Moderate improvement was defined as occasional lower intensity of joint pain with borderline uric acid level. Mild improvement was defined as uric acid level between 6.5 mg per dl and 7 mg per dl, and with sudden pain at night. No amelioration in symptoms and uric acid level remaining the same as before treatment was defined as no improvement. So the graphical analysis of the different experimental and the control group can be seen here. The age group in the experimental group and the age in the control group. The miasm in both the group, they are showing a psoric dominance. And chi-square test was carried out. And with the number of the patients involved. Now, the result sheets you can see here is the experimental group, 12 patients showed improvement and 18 patients didn't show improvement. This is the group where the medicine was prescribed on the pathological consideration. Control group, where the medicine was prescribed on the basis of totality of symptoms, showing 20 patients having improvement and 10 patients showing not improvement. On this basis, chi-square test was carried out. And on the basis of the calculations, it was determined that alternative hypothesis, that is improvement in cases of gout with homeopathic medicines prescribed on individualized consideration, is statistically significant. Now, this is an observational study and the results were obtained very quickly, and cost to carry out the study was very minimal. There was no risk of loss to follow up of the patients. The frequently indicated homeopathic medicines prescribed in cases of gout were found out, and this will help in the treatment of more such cases. Homeopathic treatment has a significant role to reduce the uric acid levels and provide symptomatic relief in treatment of patients with gout. Further studies, including randomized controlled trials and observational studies, are required to obtain a deeper knowledge of the clinico-pathological and the materia medica correlations. So that is all about my presentations. Thank you very much, and I welcome the questions that may be put up.
Thank you, Dr. Amit, for that very interesting presentation. Now I invite Dr. Sunitishuk for an interaction with the parents.
Yeah, Dr. Amit, I'd like to ask you, you said the experimental group, what medicines were given to the group, experimental group?
The experimental group, the medicines that was prescribed was Urtica urens, then it was Epigia repens and Ictholinum. So these were the 3 medicines that was given to the experimental group, where medicines were given
on the basis of the symptoms.
No, that was on the pathological basis, not on the basis of totality of symptoms. Control group, they were given medicines on the basis of totality of symptoms.
Okay. So these patients were under some other treatment as well, as you said. These are
yes, ma'am. They were under the treatment, under the traditional treatment.
Undergoing treatment for modern system of medicine.
Yes, ma'am.
So both the groups.
Both the groups, ma'am. Both the groups.
And you have not mentioned anything about the exclusion criteria.
Yes, I have not mentioned it in the slide. The exclusion criteria, the patients involved with any other pathological conditions, they were not included in the study. Basically, apart from gout, the serum uric acid level, apart from this, they were suffering from any other pathology. They were not included in the study.
Because it's very important to have exclusion criteria in a study. And another important thing is the dietary restriction with the gout. So how much dietary restrictions was prescribed for such patients? And were they following this or not?
Yes, the patients were prescribed dietary restrictions, the protein and the purine levels, the purine free diets, they were prescribed.
Okay, because you have already taken up the study with your patient already on the modern system of medicine, and then you have taken as a 2-arm study, one with the therapeutic side and one with the individualized homeopathic. So my suggestion would be, if you have to, go in for such studies, you have to have one arm with like modern medicine and another with adjuvant, rather than taking 2 arms as your own homeopathic. 2 different homeopathic treatments you are giving. One is the individualized homeopathic and one on the basis of pathological symptoms.
Yes.
So again, the patients are already on the modern system.
Yes.
So there could be some modification in the selecting the 2 arms of the study in such case.
Okay.
Yeah. Thank you.
Thank you, ma'am. Thank you. Thank you so much.
Next, I invite Dr. Akshay Khalil Ahmed Juwale. Dr. Akshay Khalil is an MD student at Dr. M.L. Thavle Memorial Homeopathic Institute, Pahavar, Maharashtra, India. His abstract ID is 337, and his topic is efficacy of similum as an adjunct therapy in the management of iron deficiency anemia in adults and growth, a randomized controlled trial. Over to you, Dr. Akshay.
Hello. Am I audible?
Yes, doctor, you're audible. Can you please share the screen?
My screen is visible to everyone?
No.
Now?
No.
Now it is visible?
Yeah, it's visible now.
Hello, good morning all. Myself, Dr. Akshay Khalil Ahmed Juwale, MD student of Pediatric Department from Dr. M.L. Thavle Homeopathic Institute, Palghar, India. So today I would like to present the efficacy of simillimum as an adjuvant therapy in the management of iron deficiency anemia in adolescent girls, a randomized control study. So now I would like to focus on the background of the study. Here, anemia is currently the most common and intractable nutritional problem globally. In India, it is estimated that about 56 of the adolescent girls are prone to anemia. And I was always wanted to learn something new which can help the future generation. In my locality, I have rarely encountered the cases of anemia and the low birth weight babies, which I observed more commonly in this tribal locality. When I was in the community posting, I observed that many pregnant women are anemic, and even though they are on iron supplement, their HB was less. Due to poor nutrition, early adolescence pregnancy, lack of awareness and education, and non-compliances to standard management strategies in the tribal community of Palghar district of Maharashtra, the maternal and infant morbidity and mortality rate is high. Also, these people have misconceived that taking an iron supplement, oral hematinics or iron supplement will lead to them a LSCS rather than the normal delivery. So this means the problem of one generation impacts the near future generation. And hence it is important to focus on the breaking this intergenerational cycle. And to break this, we need to intervene and treat the adolescent girl. So this was the topic of the study, and to find the efficacy of simillimum as an adjuvant therapy was my main objective. So in this locality, there are because of early adolescence pregnancy and the lack of awareness and the child and the after delivery, the baby more towards cases seen in the NICU and PICU, low birth weight babies, IUGR babies are more seen in this locality. So achieve this objective, I followed this methodology. So I followed that all sample was selected from the ruler setup. First, we screen all the cases clinically with consideration to a subjective and objective parameters. So such objective parameters are the pallor of conjunctiva, tongue, nail bed, palm, face, and the blood investigation. In that CBC I choose. In CBC, the indices I choose are MCV and MCHC and the morphology. The sample size was 60. So all cases were randomly distributed in two groups by using a cheat method. In first, both the groups are distributed equally, that is 30 with constitution and iron supplement and 30 with placebo and iron supplement. So complete case definition was done, but because of COVID pandemic, the school was closed. So door-to-door setups of the case definition started. And the data was, after the case definition and medicine distribution data was analyzed, then the analysis was done. In this graph, you are seeing that the mean HB of the both the groups are significantly changes seen in the CR group as compared to a placebo group. And in this graph, you can see that the first improvement seen in the CR group as early as compared to a placebo group. From these two graphs and the other parameters like grades of symptoms of HP or the grades of symptoms of IDA are seen also. Then the most improvement seen in the constitutional group. Here it is visible that the before the treatment in CR group and the after treatment in the CR group and in the placebo group. And even the comorbidity is also improved in the CR group as compared to a placebo group. And in this study, the commonly remedies are come up and frequently prescribed are the calcarea group and the natrum group. And this constitutional medicine help in improvement the susceptibility of the patient, which is more visible and significantly seen in the constitutional group as compared to a placebo group. And the data is analyzed in grouping and statistically. The significant improvement seen in the constitutional group, that the p-value is 0.00, that is less than 0.05, as compared to a placebo group on the mean difference between the pre and post HB, both the groups. That is p-value is equal to 0.0017. So constitutional medicine group registered improvement in the susceptibility as well as improvement the rate of recovery and associated complaints, help in the improving the level of HB and in bringing about the other improvement. So the constitution help to improve the susceptibility of the patient, though their nutrition is poor. And the conclusion is that from the above all the parameters that we can conclude as a similimum is efficacious as an adjuvant therapy as compared to a placebo in the management of iron deficiency anemia in adolescent girls. Thank you.
Thank you, Dr. Aksa Juwali, for the presentation. Now over to our Honorable Chair, Dr. Sumit, for her expert comments.
Study on adolescent girls. So there are many other factors like menorrhagia or something, which may be the reason for anemia in the younger age group, say about 14 or 15.
Yes, ma'am.
So these were taken into consideration in your study?
Yes, ma'am. Some in my study, some adolescent girls are complaining of menorrhagia, also heavy menstrual flow, but because of after prescription of constitutional medicine, the cause of the anemia was treated, that her menorrhagia stopped and the menstrual other complaints also did.
So there was some inclusion exclusion criteria in this regard?
In exclusion criteria, if other pathological conditions, then I will exclude this that patient. But there is no such
Because if menorrhagia is an associated complaint, so there might be difference in the results outcome when you go ahead with the study. And another is that, yeah.
I had 2 to 3 cases which are complained with menorrhagia, but after releasing the constitutional medicine, the next cycle is the flow is normal as compared to a previous.
So then you must add these things also in your
Yes.
study. And compliance to iron intake is very also very poor in such tribal areas and the village areas. So it is very important to follow up this thing also.
Yes, by evaluating all those girls, when we are treating anemic girls, we first advise a nutrition for that girls. But why evaluating a nutrition, I have big question mark. Why should I tell to eat? Because when I ask them what is available in your diet, so they always tell that the dal and rice is the available source for them. So for this, I used a food recall method to understand which iron nutrition will advise for them. So it is very difficult that because all my 60 girls are in poor socioeconomic background, so they can't even afford the iron rich diet. So whatever available sources, I advise to them.
But there were iron supplements going on, right?
Yes, in both the groups, I
that's what I'm saying. Even compliance to intake of the iron supplements is very sometimes not very good. People do not want to take iron because of so many reasons, so many myths, and maybe it is difficult to digest and something. So that is very important to follow whether they are actually taking supplements or not.
Yes,
or
ma'am.
just
They are
going up the pills.
They are taken up, but in our literature, they have mentioned that with the iron supplement, there are complaints of constipations and other such. Girls are complaining that the smell is bad, but because of constitutional medicine, that's all that constipation and other things will not affect the child's health.
Although study was taken in a poor area,
Yes.
economically poor background, but other studies like iron studies, serum ferritin, transferrin, these are also very important for to assessing the outcome of the study.
Yes, ma'am. When I was prepared my synopsis, I evaluate all the in financial status of the child, and that time we conclude that the serum ferritin and TIBC is more expensive. So the cheapest is available is CBC. In that MCV and MCHC is the to conclude that it is the iron deficiency anemia.
Yeah, maybe at the later stage you can have such studies in a larger setup and with all such test and criteria set up, maybe set up for the larger scale studies.
Yes, ma'am.
Yeah.
Thank you.
Thank you. I think we can go ahead with the next one.
Yes. Now I call upon the next speaker, Ms. Paulmi Sarkar. Dr. Paulmi Sarkar is an internee at Calcutta Homeopathy Medical College and Hospital. The topic for presentation is effectiveness of magnesium phosphoricum 6X in comparison with individualized homeopathy treatment of primary dysmenorrhea, an open randomized pragmatic trial. And the abstract ID is 3.
Good morning, everyone. Myself, Polumi Sharkar. I'm an internee from the Calcutta Homeopathic Medical College and Hospital, Kolkata. Today, I'm here to present my work on effectiveness of magnesium phosphoricum 6X in comparison with individualistic homeopathic treatment of primary dysmenorrhea, an open randomized pragmatic trial. Dysmenorrhea is a very common health issue among the young girl, and it causes painful menstruation in such a intensity that it incapacitates the girl for its day-to-day activities. I will not go into detail of the signs, symptoms, and of dysmenorrhea and the causes of dysmenorrhea, as we all well aware of it. I will rather tell that why I took up the study. Though dysmenorrhea is a very common health issue among young girls, we commonly do what? We take painkillers or say it's just indiscriminately. And we also know that these medicines have very high high failure rate. So there remains a very large scope for our homeopathic medicine in treatment of primary dysmenorrhea. So when I went through the literature, we saw that it is mentioned in literature that magnesium phosphoricum is a great antispasmodic remedy, especially in 6x potency. It has great potential to lower the pain of primary dysmenorrhea. So among us homeopaths, there is common notion that we just indiscriminately use magnesium phosphoricum in lowering the pain of primary dysmenorrhea, though our philosophy tells us to use individualistic homeopathic medicine. So the aim of this RCT was to see the compare the changes holistic homeopathic treatment and magnesium phosphoricum in 6x potency. The objective of my study was to compare the changes in mean pain intensity as per numerical rating scale of primary dysmenorrhea among the two groups, and to compare the changes in verbal multidimensional scoring system to assess the dysmenorrhea severity and associated symptoms of primary dysmenorrhea in the two groups. The first I took null hypothesis, that is there is no difference between the mean pain intensity as per numerical rating scale in between the two groups, and my alternate hypothesis was there may be some difference in pain intensity in numerical rating scale during menstruation between the two groups. The study was carried out at the Gynae Outpatient Department of the Calcutta Homeopathic Medical College and Hospital. The study duration was 6 months. The study was carried out from 15th November to 15th May 2019, and study population was 12 to 30 years of females who were reporting to the Gynae Outpatient Department of the Calcutta Homeopathic Medical College. It is a prospective open randomized trial, and we included those patients who were of 12 to 30 years of age group, suffering from menstrual pain on the day, especially on the day one, and having menstruation for more than 6 months, and not diagnosed with any other uterine pathology, and consented for the to join this study. And those patients who were having any secondary uterine pathology which indicated secondary dysmenorrhea, or who are having OCPs and IUC, who had IUCD, or pregnant or lactating mother, or even having any psychiatric illness or substance abuse, we excluded those patients. There was no such study previously present, so keeping in mind the time issue, the a limitation of the study, we took 60 patients, and 30 patients were taken in each group as per the randomized chart that is generated by the computer. Uh, the first intervention for my study was magnesium phosphoricum 6x in individualized doses, and it was given to the patient to take up with half cup of warm water when the patient was experiencing the menstrual pain during the 3 months. And thus, my second intervention was individualistic homeopathic medicine in centesimal potency for the duration of 3 months. Uh, the second primary outcome for my study was pain intensity as per numerical rating scale, which was taken at baseline, first month, second month, and third month. And the secondary outcome for my study was verbal multidimensional scoring system, which was taken only at baseline and during the third follow-up. The study protocol was presented in front of the ethical committee, and ethical clearance was obtained. No new drug was used. We took 89 screened 89 patients, and 60 of them met the eligible criteria, and 30 was taken in each group as per the randomized chart. And we lost for follow-up 4 patients in the individualized group and 3 patients in the 3 patients in the magnesium phosphoricum group. For the baseline features, the mean age for the individualistic homeopathic group it was 19.1 year, and for the magnesium phosphoricum group 18.2. The marital status and menstrual cycle, there was no all other respect the two groups were comparable. So after continuing the study for 3 months, the pre-post comparison between the two groups was done by peer t-test and repeated measure ANOVA. And except from the date for the day 2 of second month, for the first month, first day and verbal multidimensional scoring system, the changes were statistically significant in individualistic homeopathic group. There was changes in intergroup changes in both groups, as we can all see here, but the changes were individualistic homeopathic group were better. Individualistic homeopathic group gave better result in both numerical rating scale and for verbal multidimensional scoring system, for physical score, for psychological score, and for the social score. For the individualistic homeopathic group, the most commonly used medicine was for my study was natrum muriaticum, and followed by pulsatilla, nitric acid, sepia, sulfur, and other well-proved medicine. To conclude, I can say that conventional medicine has 20 to 25% failure rate along with its side effect. Here remains a great scope for homeopathic medicine. And with this study, we can see that individualistic homeopathic medicine gives better result, much more better result than magnesium phosphoricum 6x in case of primary dysmenorrhea. The limitation for my study was that the study was underpowered, the sample size was very low, and cautious interpretation in future is necessary. So we can give management for primary dysmenorrhea to these young girls and give them a healthy and happy womanhood. This study was reported as per consort guideline. The study was carried out in the short-term studentship in homeopathy 2018. This was all about my presentation. Thank you so much, LMHI, for this beautiful platform. Thank you so much, everyone.
Thank you, Dr. Pawnvi Sarkar. Now I invite our Honorable Chair, Dr. Stuti, to interact with the panel.
Yes, Dr. Palami, you have taken a very nice study, and as your study concluded that individualized homeopathic treatment has a better results rather than magnesium phosphoricum. So to further authenticate this outcome, so placebo control trial should be taken up, because you are already comparing two homeopathic groups. So the efficacy of individualized homeopathic medicine should be taken up along with the control trial with the placebo as a one trial arm. So this should be taken up in future, and maybe magnesium phosphoricum, a separate study may also be taken, because magnesium phosphoricum is also very effective antispasmodic and shown very good results in dysmenorrhea. So another study with the
yes,
placebo control arm and magnesium phosphoricum may also be taken up. Yeah. Overall,
yes,
a nice initiative.
Thank you, ma'am. And with the permission of the chair, let me call upon our last speaker of this session. Dr. Kalyan Chakrabarti is an intern at the Calcutta Homeopathy Medical College and Hospital. The topic for today's presentation is effectiveness of natrum muriaticum in comparison to individualized homeopathy treatment of wrist ganglion, an open randomized equivalence trial. And the abstract ID is 381. Over to Dr. Kalyan Chakrabarti.
Yeah, am I audible clearly?
Yes, you are loud and clear. You may please start screen share.
My screen is visible.
No, no, doctor, not right.
Is visible now?
No. Yeah, it's visible. No, it's not visible.
Now it is visible.
Yeah, it's visible, and you can zoom on also, so that it will be more clear. Yeah, it's clear now.
Is it clearly visible?
Yes.
So, very good afternoon to the judges and all the other fellow speakers. This is Kollan Chakraborty from an internee of the Calcutta Homeopathic Medical College and Hospital. The study that I had undertaken was effectiveness of Natrum muriaticum in comparison to individualized homeopathy uh, Natrum muriaticum in comparison to individualized homeopathic treatment in case of wrist ganglion cyst. It was an open, randomized, and equivalence trial. Now we know that in the modern era, the evidence-based medicine is the norm. The practitioner of the complementary and alternative system practitioners are increasingly challenged to show their improvement in the treatment by uh, independent randomized control trial. So, and also this randomized control trial is the hallmark of the evidence-based medicines. The 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 topic that I am going to discuss is the ganglion cyst is a benign non-soft tissue tumor of the joint and tendon sheath that is most commonly encountered in the wrist but may occur in any other joints. Now, in homeopathy, Master Hahnemann advised all of the homeopaths to consider exclusively on the totality of the symptoms to prescribe any of the medicines. But according to Barnett's indication, Natrum muriaticum is also very much effective uh, for the treatment of wrist ganglion cyst when empirically prescribed. It is a literature review, but it is also very much evident in the different outpatient departments of our college. So that leads me to take up this study further. Our objective compare the was to compare the reduction of the size of the wrist ganglion cyst after empirically prescribed Natrum muriaticum and after individualized homeopathic treatment. And also the other objective was to compare the change in the wrist pain and other disabilities associated with the wrist ganglion cyst after empirically prescribed Natrum muriaticum and individualized homeopathic treatment through patient-rated wrist evaluation questionnaire. We conceptualized the study hypothesis. Null hypothesis was taken that there is no difference between the mean size reduction of the wrist ganglion and pain intensity functions as per PRWE code in between empirically selected Natrum muriaticum and individualized medicines. And an alternative hypothesis was also taken, which was there may be some difference between the two groups regarding this questionnaire and also in the pain score. The study site was outpatient departments of the Calcutta Homeopathic Medical College and Hospital. It was a 6 month. The study duration was 6 months, and the study population was any of the adult patients of above 18 years of age, and who were reporting the our outpatient departments. There were certain inclusion and exclusion criteria which was taken. The sample size, there was no calculations regarding this study. We have taken only 30 patients to uh, for as our sample size. There was randomization process, and now I am going to the study flow chart. We have included 71 patients, and who are fulfilling the eligibility criteria. After considering the exclusion criteria, there were 11 patients who were excluded for different reasons. And after that, the randomization process was done, and through a computer generated random number table. And according to that table, 30 patients were prescribed with individualized homeopathic treatment, and 30 patients were prescribed with Natrum muriaticum and in 2 arms. All the statistical information that was taken that was compiled in an Excel spreadsheet, and the mean values and other statistical calculations that were carried out, and that was carried out in both the groups and then compared between two groups. We have seen that female patients were 37 patients and 23 patients were male, and it also that locations 48 patients that were those having the wrist ganglion cyst on the dorsal aspect of the wrist, and 68.33 patients, that number of 41 patients having the wrist ganglion cyst on the right upper leg. According as we calculated the mean values in the baseline after first month, second month, and third month, and then the mean values of both the arms were calculated, and t-test all of subsequently all the the sub questions of the PRW, patient rated risk evaluation questions, all the sub questions that was there, and t-test was done in all those sub questions, like the size reduction in the wrist ganglion cyst. In most of the size reduction of the wrist ganglion cyst, and also in the usual activities, specific activities, and also in the pain score. In only in the specific activity, there was the p value is significant, though we saw that in most of the cases individualized homeopathic treatment gave more beneficial result than than the empirical basis of prescription of Natrum muriaticum, but it was only statistically significant in the specific activity. In all other groups, it is not statistically significant, though more beneficial than this Natrum muriaticum, empirically prescribed Natrum muriaticum. And also individualized homeopathic treatment, Ruta graveolens, Calcarea fors, Thuja occidentalis, Cali muriaticum were the mostly prescribed medicines. In the conclusion, as we can see that in the study of wrist ganglion cyst, after the statistical analysis, we find that the treatment through Natrum muriaticum was less beneficial than individualized homeopathic treatment, and the individualized homeopathic treatment is beneficial statistically significantly only in the case of specific activities, in the sub question of specific activities, and further research work with this topic, as there was no I mean during the literature review there was very few, or one or two, or very less number of research was done regarding the wrist ganglion cyst, and there was mentioning of the Natrum muriaticum in the homeopathic literature is also very less. In synthesis and other repertories also it is not so much indicated. So that's why Natrum muriaticum may be considered, but individualized homeopathic treatment here it is giving the more beneficial result. In only one case it is giving the statistically significant result, and it was also a topic of short-term friendship program of 2018 under Central Council of Research in Homeopathy. Thank you for listening me. This is all from my side. Thank you.
Thank you, Dr. Kalyam, for that innovative work and the presentation. Now to Dr. Suniti for expert comments on this presentation.
Yeah, Dr. Kalyan, why did you decide to choose Natrum as a one arm for the study?
Because Natrum in the OPD, during our OPD visit, I found that when Natrum was prescribed according to empirical prescription, and two of my senior teachers and visiting physicians of our OPDs, they used to prescribe on the basis of that Barnett's indication of giving Natrum empirically in case of wrist ganglion cyst.
Natrum in itself is a polycrest remedy. So just giving Natrum just on the basis of diagnosis is it is not well established treatment for the wrist ganglion. As you said in the previous study, magnesium phos was taken as one arm because magnesium phos is considered to be a very effective antispasmodic. And Natrum in itself is a polycrest remedy, and we are comparing two arms with the one is Natrum and another is individualized homeopathic treatment. And you said, as you said, there are not too many studies on this. So first of all, my suggestion would be that this study should be taken up as a pilot study, should be taken as 1 arm as a placebo control. And then you compare it, either you can compare it with the Natromure to see the efficacy of Natromure, or maybe you can take up with the individualized homeopathic treatment. But 1 arm should be a placebo control. This would be my suggestion for future.
Okay, ma'am. Okay, ma'am.
Thank you.
Thank you, ma'am.
Okay, so that was our last present of the session. And indeed, the session was very interesting, and we got many papers on randomized control trial. And one of the observations that many youngsters, especially interns and PG scholars, has come up with studies on randomized control trials on various topics. That is a welcome sign. And now I invite our honorable chair, Dr. Suniti Shuk, for the closing remarks. Over to you, ma'am.
Yeah, thank you. Overall, it has been a very nice session, and we got to hear so many budding researchers on various RCTs, which are gold standards on comparative studies. And but overall, I would suggest that all these studies must be taken up in a larger setting, and maybe multi-centric trial would be much better. And as I suggested in the individual studies, these suggestions may be taken up, and I congratulate organizer for such a nice session and all the speakers who were really nice in their presentation. That's it. Thank you so much.
Thank you, ma'am. On behalf of the LMHI, I thank you for sharing your valuable time with us and encouraging our participants and giving you valuable suggestions that indeed will help them for their future endeavors. On behalf of LMHI, I thank all the participants for sharing your valuable time. Not the least, my co-moderator, Dr. Cheshta, and our session coordinators, Dr. Swati and Dr. Ritika, for sharing this, for sparing their valuable time. Thank you once again on behalf of LMHI. Thank you all. Stay safe, stay healthy. Have a great day. Thank you.
Thank you, everyone.
Thank you.